In this video, we are going to learn about nursing and foundations of nursing excellence. Let's begin.
Nursing operates at a strict intersection. It requires precise clinical science and absolute legal accountability. Gathering raw physiological data, like a heart rate or temperature, is only the first step. A nurse must interpret systemic stability from those numbers and execute care within a rigid ethical framework. We will map this progression, starting with the objective baselines of vital signs and thermoregulation. From there, we move outward to the operational protocols of delegation, and finally into the legal constraints that govern practice. This movement from raw data to ethical execution is the standard that defines nursing as a life-saving clinical discipline. Vital signs serve as the objective, non-negotiable baselines of a patient's systemic health. This dashboard shows adult normal ranges. Temperature sits between 96.4 and 99.5 degrees. Pulse operates from 60 to 100 beats per minute. Respirations range from 12 to 20 breaths. Blood pressure stays below 120/80, and oxygen saturation holds between 95 and 100%. When those numbers drop, assessment locations matter. Central pulses at the carotid and femoral arteries verify core body perfusion during severe hypotensive drops, while peripheral pulses in the extremities are strictly for assessing localized limb circulation. To accurately identify a dysrhythmia, the apical pulse must be auscultated with a stethoscope for exactly 1 full minute. Blood pressure assessment requires physical precision. The nurse must select the correct cuff size and precisely align the artery indicator label over the brachial artery. Modern automated vitals rely on the historical mechanical precision established by early sphygmomanometers. Relying blindly on automated monitors introduces the risk of false readings, known as artifacts, particularly in pulse oximetry. If a patient has severe peripheral vasoconstriction, like cold hands, or is wearing acrylic fingernails, the optical sensor on the pulse oximeter becomes blocked, skewing the data. Respiratory data must also be carefully verified. Tachypnea occurs when the rate exceeds 24 breaths per minute, while bradypnea is defined as fewer than 10. Failing to account for technical variables or artifacts corrupts the clinical baseline. If the initial data is wrong, every subsequent patient care decision is misdirected. Core body temperature is tightly controlled by the hypothalamus, which acts as the brain's thermostat to dictate systemic heat loss and production. This schematic maps the specific functions of the hypothalamus. The anterior hypothalamus controls heat loss, triggering sweating and vasodilation to cool the body. The posterior hypothalamus controls heat conservation, triggering vasoconstriction and rapid shivering to increase metabolic rate. When molecules called pyrogens enter the system, they disrupt this thermostat, causing hyperthermia. This state progresses from early signs like shivering and hot, dry skin to late and dangerous neurological signs like confusion and delirium. Pharmacological intervention carries strict contraindications. You must never administer aspirin to children or adolescents with a viral fever. Doing so introduces a fatal risk of Reye's syndrome, which causes acute brain swelling and catastrophic liver damage. Acetaminophen is also heavily restricted. Because it is metabolized exclusively by the liver, the absolute maximum adult dose is 4 grams per 24 hours to prevent severe hepatotoxicity. On the opposite end of the spectrum, hypothermia poses extreme risks to neonates. Newborns have a large surface area and thin skin, and they lack the physiological ability to shiver, causing them to lose heat rapidly. Tracking these core temperatures often requires a rectal thermometer for maximum accuracy. However, this route is strictly contraindicated for patients with neutropenia, low platelets, or spinal cord injuries. Effective thermoregulation is an active process of anticipating metabolic crises and avoiding lethal pharmacological errors. It is never just about recording a value. Because clinical demands consistently exceed the capacity of a single clinician, nurses must safely delegate specific tasks to licensed practical nurses and unlicensed assistive personnel. While the physical task is delegated to another staff member, the registered nurse retains ultimate legal accountability for the patient outcome. To manage this liability, the law requires adherence to the 5 rights of delegation. First, verify the right task and circumstance. Next, assign the right person and provide the right direction so instructions are perfectly clear. Finally, right supervision and evaluation must close the loop. Failing any one of these 5 checks transforms delegation into an act of legal negligence. Every delegated task, vital sign, and intervention must be recorded in the electronic health record, which serves as the ultimate legal blueprint of care. The electronic health record establishes baseline physiological data, identifies dangerous changes in consciousness, and provides the only legal proof that professional standards of care were met. This brings us to the absolute legal maxim of the nursing profession. If it wasn't documented, it wasn't done. Beyond hospital protocols, nursing is regulated by 2 parallel frameworks. Ethics govern moral conduct, while laws enforce strict regulatory and penal compliance. The core principles of bioethics require a nurse to practice beneficence, acting in the patient's best interest, non-maleficence, which means doing no harm, and justice, guaranteeing fair and equal care. Crucially, these principles are checked by autonomy. A patient's right to informed consent and their legal right to refuse care completely supersedes a nurse's desire to intervene. Violating legal standards leads to tort claims. Unintentional torts occur when harm is caused accidentally. Standard negligence involves failing to perform an expected action, while malpractice occurs when a professional's specific negligent action directly causes harm to a patient. Intentional torts involve willful actions. These include assault, which is the threat of physical harm, battery, which is unconsented physical contact, and false imprisonment, defined as the unjustified restriction of a patient's movement. Information security carries the exact same legal weight. The federal mandate of HIPAA establishes strict patient privacy boundaries, highlighting the severe professional risks of using social media in a clinical setting. Good intentions, such as a student nurse wanting to share a photograph of a pediatric patient's bravery, do not mitigate the legal consequences of a privacy breach. Unauthorized chart access, sharing passwords with colleagues, or simply failing to log off a workstation are fireable offenses that can lead to immediate license revocation. Securing patient data requires every terminal and chart to remain locked behind strict digital protocols at all times. Ultimately, clinical brilliance is legally irrelevant if it is achieved by violating patient autonomy, consent, or digital privacy. The practice of nursing forms an unbroken chain of accountability. It begins at the patient's bedside, the moment the first blood pressure reading is taken. That data must flow flawlessly through the operational channels of safe delegation, ending as meticulous documentation in the electronic health record. This modern data-driven approach is a direct evolution of the hospital standards and accurate record-keeping first established by Florence Nightingale. Today, that legacy operates under a dual mandate. A nurse must provide aggressive, evidence-based physiological intervention while remaining entirely constrained by legal statutes and bioethics. Navigating the friction between rapid clinical action and strict ethical boundaries is exactly what defines a competent, highly trusted professional nurse.